We're going to start with the language of the heart itself, the ECG, all the fundamentals of electrical conduction.
Yep, the basics.
From there, we'll move to what you can find on the physical exam. We're talking heart murmurs, peripheral pulses, all those classic clues.
The hands-on part.
Then we dive into the chaotic world of heart rhythm disorders, the arrhythmias. And finally, we'll confront the big systemic failures, heart failure, the different muscle diseases or cardiomyopathies, and how to manage acute coronary events.
It's a lot, but it all fits together. By the end, you should have a really solid synthesis of the whole picture.
Let's do it. Where do we begin?
We have to start with a foundational tool, the one that captures the heart's electrical signature. It's where every single cardiac assessment begins.
The ECG?
The ECG.
So for anyone looking at one of these tracings, what are we actually trying to capture? What is the goal of the ECG?
Well, the ECG, the electrocardiogram, is so much more than just a rhythm strip. It's really a comprehensive assessment of the heart's electrical activity. We're talking about 6 key domains.
6, so it's way more than just looking for a heart attack.
Yeah. Oh, absolutely. We're looking at the heart rate, of course.
Yeah.
Then the rhythm, the electrical axis.
Right, the direction of the current flow.
Exactly. Then the intervals between the waves, which tells us about conduction.
Yeah.
And then, yes, signs of ischemia. And finally, evidence of whether the chambers themselves are enlarged. It's a complete, non-invasive window into the heart.
And the very first thing you do when you pick up that piece of paper is check the rate. What's the fastest, most high-yield way to calculate it?
Absolutely. Rate first. So, assuming a standard paper speed, the trick is the key fact. 300 divided by the number of large boxes between 2 consecutive QRS complexes.
Simple as that.
Simple as that. If there are 2 big boxes, the rate is 150. If there are 3, that's 100. 4, it's 75. It's a very quick estimation.
So once we have that number, how do we frame it clinically? What are the basic definitions?
The normal adult heart rate is defined as 60 to 100 beats per minute. Anything below 60 is bradycardia, and anything over 100 is tachycardia.
But those are just numbers. They're kind of useless without context, right?
Completely useless. Let's take bradycardia, a slow heart rate. When does that actually become a problem?
Okay.
Well, sinus bradycardia, where the rhythm is normal, just slow, can be totally physiological. You see it all the time in highly conditioned athletes.
Their hearts are more efficient.
Exactly.
Yeah.
But pathologically, we have to immediately think about a few things. First, drugs. Beta blockers, calcium channel blockers, digoxin. Then we think about intrinsic disease like sick sinus syndrome, where the SA node itself is failing.
And acute emergencies.
Yes, things like an acute MI, especially an inferior one that affects the blood supply to the AV node, or even things like increased intracranial pressure.
Okay, so what about the other side of the coin? Tachycardia. A fast heart rate often means the body is trying to compensate for something, right?
That's the key. Tachycardia is highly nonspecific, but it is a critical sign of stress. The list of causes is huge.
Like what?
It could be anxiety, anemia, where the heart speeds up to deliver the limited oxygen, fever, sepsis, hypovolemia, just simple pain.
So a lot of non-cardiac causes.
A ton. But also severe cardiopulmonary issues. Think congestive heart failure, shock, a big pulmonary embolism, or even hyperthyroidism. You have to investigate the root cause. Just treating the fast heart rate is missing the point.
Okay, so we've covered rate. Let's move to rhythm. The gold standard is normal sinus rhythm. What electrically defines that pattern?
So normal sinus rhythm means the electrical impulse starts where it's supposed to, in the sinoatrial, or SA, node, the heart's natural pacemaker.
And there are some non-negotiable rules for that on the ECG.
Absolutely. You must have a P wave, which is the atrial depolarization, and it has to be upright in leads I, H2, and AVF. That P wave has to come before every single QRS complex.
And vice versa.
And vice versa. A QRS complex, which is the ventricular depolarization, must follow every single P wave that confirms the signal got through the AV node correctly.
But what if the rhythm starts in the right place, but it's still irregular?
That brings us to sinus arrhythmia. This is actually a normal variant, especially in younger people, and it's tied to breathing.
The respiratory cycle.
Exactly. The rhythm originates from the SA node, but there's a cyclical beat-to-beat variation in the ventricular rate. The RR intervals change. But crucially, the PR interval stays constant. That tells you the conduction itself is fine. It's just the timing of the SA node firing that's a little irregular with breathing.
Okay, so we've gone from timing to, geometry. The QRS axis. For us visual learners, this is basically the average electrical path the impulse takes through the heart.
So it's a perfect way to put it. The QRS axis is the average direction of that mean QRS current flow. And we can figure it out just by looking at whether the QRS is pointing up positive or down negative in two specific leads.
Which two?
The key two are lead I and lead AVF. You can visualize it on that 36-degree hemisphere diagram you see in textbooks. A normal axis falls between -30 and +90 degrees.
It's amazing that just checking the polarity in two leads can tell you so much. So let's break down the deviations using that method. First, a normal axis.
A normal axis means the main depolarization vector of the left ventricle is flowing down and to the left towards leads AVI and AVF.
So they should all be positive.
Exactly. You get an upward positive QRS deflection in those leads. It confirms the electricity is taking its normal highway.
So what happens when that axis shifts far to the left? Left axis deviation, or LAD? What does that pattern look like in our two key leads?
With LAD, the vector has shifted strongly upwards and leftwards. So it's still moving towards lead I. So you get a positive QRS in lead I.
But it's moving away from AVF, which looks at the heart from the bottom.
Precisely. So you get a negative QRS deflection in AVF. The causes are usually things that either make the left side of the heart bigger, like left ventricular hypertrophy, or that mess with the conduction down the left side, like a left anterior hemiblock or an old inferior MI.
Thumbs up, thumbs down. And the opposite, right, axis deviation, RAD.
With RAD, the vector shifts strongly down and to the right. So now the impulse is moving towards AVF, giving you a positive QRS there.
But away from lead I.
Away from lead I, giving you a negative QRS in lead I. Clinically, this points to problems on the right side of the heart, things like right ventricular hypertrophy or an anterolateral MI, and critically, you always have to consider an acute cause like a massive pulmonary embolism.
And then there's the really weird one, extreme axis deviation. What does it mean if both lead I and AVF are negative?
Extreme axis means the vector is going up and to the right in no man's land. It's opposing both lead I and AVF. The electrical trajectory is just fundamentally messed up.
What causes that?
It can be something as simple and embarrassing as misplacing the limb. These are a common error. But it can also signal very serious problems, like an intrinsic ventricular rhythm or if the heart is being paced from the ventricle.
Okay, so we've seen the big picture. Now let's pull out the ruler and measure the milliseconds. Timing is everything for diagnosing conduction disease. Let's start with the PR interval.
The PR interval. This is the time it takes for the signal to get from the atria, pause in the AV node, and get to the ventricles. Normal duration is 120 to 200 milliseconds.
Or 3 to 5 of those little boxes on the paper.
Right. If that interval is prolonged, longer than 200 milliseconds, that defines a first-degree heart block. It's just a delay at the AV node.
And if it's too short?
A shortened PR interval means the impulse is bypassing that normal AV node delay. It's taking a shortcut. That's the classic finding in Wolff-Tarkenton-White syndrome, or WPW, which we'll get into more detail on later.
Okay, next up, the QRS interval. This is the speed of the ventricular depolarization itself. How fast should that be?
It should be very fast. The QRS should be less than 120 milliseconds or less than 3 small boxes. A widened QRS is a huge red flag.
Why?
Because it means the conduction within the ventricles is slow and inefficient. This signals either a conduction defect, like a bundle branch block, or that the impulse is starting from a weird place within the ventricle itself.
Let's compare the two big types of bundle branch blocks. It's critical to recognize these instantly.
Okay, so in a right bundle branch block, or RBBB, the signal is delayed going down the right bundle. The classic signature is what we call rabbit ears, an RSR prime complex, best seen in lead V1, and the QRS will be wild.
And the left bundle branch block, LBBB, which is generally more serious.
It is. The hallmarks of an LBBB are a wide, often notched QRS. You'll see what looks like an M shape in the lateral leads like IAVL in V6, and a deep S wave, a W shape, in V1.
So what's actually happening there?
It means the left side of the heart is depolarizing late. The impulse travels down the right side first and then slowly spreads across the muscle to the left side.
Now, LBBB is a huge masquerader because it can completely hide an acute heart attack on the ECG. How do we use the Scarbossa criteria to see past that block?
This is a critical clinical tool. First off, a brand new LBBB is often treated as a STEMI equivalent by itself. But if the LBBB is old, we use the Scarbossa criteria to look for an MI.
What are we looking for?
We're looking for clues that are out of place. Specifically, concordant ST elevation of at least 1 millimeter in a lead with a positive QRS, or excessively discordant ST elevation of at least 5 millimeters, where the ST segment is pointing way, way opposite the direction of the QRS. These signs tell you acute ischemia is happening underneath that confusing LBBV pattern.
Okay, last interval, the QT interval. This represents the entire cycle of ventricular depolarization and repolarization. And when it gets too long, it's not just an abnormal number, it's risk for sudden death.
It absolutely is. The QT interval, corrected for rate, or QTC, should be around 380 to 440 milliseconds. QT prolongation is exceptionally dangerous because it destabilizes the whole electrical system.
And sets the stage for what?
It sets the stage for a life-threatening arrhythmia called torsades de pointe, that twisting pattern.
What are the main culprits that make the QT interval too long?
We can group them into acquired or congenital. Acquired causes are huge. First, severe electrolyte problems, specifically low potassium, low calcium, and low magnesium.
And then there's the medication list.
An absolutely massive list. You have to know the big ones. Macrolide and quinolone antibiotics, most antiarrhythmics like amiodarone and sotalol, and even some antipsychotics and opioids.
And what about the two big congenital long QT syndromes? We have to screen for these in any young person with fainting spells.
The two big ones are Romano-Ward syndrome, which is autosomal dominant and is purely cardiac.
No deafness.
Right. And then Jervell and Lange-Nielsen syndrome, which is autosomal recessive and comes with sensorineural deafness along with the long QT. It's usually more severe.
And the treatment is aggressive.
Very aggressive. It's all about prevention. So chronic beta blocker therapy and often placement of an implantable defibrillator, an ICD, especially if they've had symptoms.
Let's shift to how an actual heart attack evolves over time on the ECG. It's a dynamic process, changing by the hour.
It really is. In the acute phase, seconds to minutes, you see these hyperacute, very tall peak T waves, and then the ST elevation begins.
Then what happens over the next day or so?
In the subacute phase, usually less than 24 hours, the ST elevation is fully established and you start to see the T wave inverting.
And how do we spot the permanent damage later on?
Well, post-acute, after 24 hours, is when the pathological Q wave starts to appear. That's the sign of tissue death, of necrosis. The T wave inversion gets deeper. Then, in the chronic phase, days to years later, the ST segment usually goes back to normal, but those Q waves often remain as a permanent electrical scar.
Speaking of Q waves, what makes a Q wave pathological? When does it stop being normal and become evidence of an old heart attack?
The criteria are pretty strict. A pathological Q wave has to be more than 40 milliseconds wide, one small box, or its depth has to be more than 1/3 of the total height of the QRS complex in that lead.
Okay, beyond specific waves, we can also look for chronic stress on the heart by looking for chamber enlargement. Let's start with the atria.
Right. Atrial enlargement suggests chronic pressure or volume overload. For the right atrium, we call it P pulmonale.
P for pulmonary.
Exactly. It results from chronic conditions that strain the right side of the heart, like COPD, pulmonary embolism, or tricuspid stenosis. On the ECG, you see these tall, peaked P waves, best seen in leads 2, 3, and AVF.
And for the left atrium, it's P mitral.
P mitral, right. This is associated with high pressure in the left atrium, often from things like LV hypertrophy, hypertension, or mitral valve disease. The signature finding is a broad, often notched P wave in lead 2, and crucially, a deep negative deflection of the P wave in lead V1.
Moving to the big chambers, the ventricles, left ventricular hypertrophy, LVH, is often from years of high blood pressure. How do we see that on the ECG?
A bigger muscle generates a bigger electrical signal, so we use amplitude criteria. The most common one is adding the depth of the S wave in V1 to the height of the R wave in V5 or V6. If that sum is greater than 35 millimeters, that's a strong indicator of LVH.
All right, ventricular hypertrophy, RVH.
RVH, maybe from pulmonary hypertension, is flagged by a right axis deviation and a tall R wave in V1 that's 7 millimeters or more. This tells you the right ventricle, which is normally electrically smaller than the left, is now generating a huge signal.
That's a perfect synthesis, linking those electrical patterns directly to the structural changes in the heart. Okay, let's transition from the electricity to the physical exam, where we can hear and feel what the ECG is suggesting.
Exactly. The physical exam gives you invaluable, immediate clues. And we often start with looking for external signs of fluid backup and pressure.
Jugular venous distension, JVD.
JVD. You have the patient at a 30 to 45 degree angle, and you're looking at the height of the venous pulsation. If it's more than 3 centimeters above the sternal angle, that's elevated.
And what does that tell you?
It's a direct sign of high right-sided heart pressures. It means there's volume overload. You see it in right heart failure, severe tricuspid regurgitation, or pulmonary hypertension.
There are a couple of related signs too, right? Hepatojugular reflex and Kussmaul sign.
Yes. Hepatojugular reflux is when you press firmly on the liver and you see the neck veins distend and stay distended. It confirms those high filling pressures.
And Kussmaul's.
Kussmaul's sign is really specific. It's a paradoxical rise in the JVP when the patient inspires. Normally, it should fall. A rise means the right ventricle can't expand to accept the extra blood. It's the classic sign of constrictive pericarditis.
Now let's move to listening. The extra heart sounds, the gallops. S3 and S4. These are huge clues about the state of the ventricles, whether the problem is weakness and dilation or stiffness.
The distinction is absolutely vital. The S3 gallop, which sounds like Kentucky, is a low-pitched sound of a rush of blood hitting a dilated, floppy ventricular wall.
So it's a sign of volume overload.
It's a sign of volume overload and systolic failure. You hear it in dilated cardiomyopathy, severe heart failure. It can be normal in pregnancy or in athletes, but in a patient with dyspnea, it's a very bad sign.
So S3 is about a weak, dilated heart. What about S4?
The S4 gallop, which sounds like Tennessee, is almost always pathological. This is the sound of the atrial kick trying to force blood into a stiff, non-compliant ventricle.
So it's a stiffness problem.
It's a stiffness problem. Diastolic dysfunction. You hear it in conditions of chronic pressure overload, like long-standing hypertension, aortic stenosis, and especially in hypertrophic cardiomyopathy.
Okay, before we dive into the specific murmurs, let's just quickly review the main listening posts on the chest.
Right. Aortic area is the second right intercostal space. Pulmonic is the second left. Tricuspid is the lower left sternal border. And the mitral area is the apex, usually around the fifth left intercostal space, mid-clavicular line.
Okay, murmurs. They're defined by timing. Systolic between S1 and S2, or diastolic between S2 and S1. Give us the simplified high-yield list for each category.
So for systolic murmurs, you're thinking about either stenosis of the outflow valves, aortic and pulmonic stenosis, or regurgitation of the inflow valves, mitral and tricuspid regurgitation.
And diastolic.
Diastolic murmurs are the opposite. It's either regurgitation of the outflow valves, aortic and pulmonic, or stenosis of the inflow valves, mitral and tricuspid.
Let's get into the details of the two most common ones: aortic stenosis and mitral regurgitation.
Okay, aortic stenosis is this harsh, crescendo-decrescendo systolic ejection murmur. It's loudest at the aortic area, and it classically radiates up into the carotid arteries in the neck.
And mitral regurgitation.
Mitral regurgitation is a holosystolic or pansystolic murmur. It lasts throughout systole. It's usually loudest at the apex, and it radiates out towards the axilla. It's often a sign that the ventricle is dilated and stretching the valve open.
There's another big systolic murmur we have to differentiate from a ventricular septal defect, or VSD.
Right. A VSD also causes a harsh holosystolic murmur, best heard at the left lower sternal border. And here's a key paradox. Smaller VSDs often have louder murmurs.
Why is that?
Because the pressure gradient between the left and right ventricle is higher across a smaller hole, which creates more turbulence and a louder sound.
Okay, moving into diastole. Aortic regurgitation, or AR.
Aortic regurgitation is a high-pitched, blowing, early diastolic decrescendo murmur. It's the sound of blood leaking back into the LV right after the aortic valve closes, best heard at the aortic area or along the left sternal border.
And then there's the very unique sound of mitral stenosis.
Mitral stenosis creates this low-pitched diastolic rumble. You really need to use the bell of your stethoscope at the apex to hear it well. It's often preceded by an opening snap, the sound of that stiff stenotic valve being forced open.
And the length of the rumble tells you how bad it is.
Exactly. A longer rumble means more severe stenosis.
And we can't forget the only murmur that's continuous through both systole and diastole.
That would be the patent ductus arteriosus, or PDA. It creates a continuous, machine-like murmur that's loudest around S2. You hear it best in the left infraclavicular area. It's the sound of constant flow from the high-pressure aorta to the low-pressure pulmonary artery.
Now, here's a really crucial physiological trick that helps us at the bedside: the effect of breathing.
This is a fundamental principle. When you take a deep breath in, you increase venous return to the right side of the heart.
More blood flow.
More blood flow through the right-sided valves. Therefore, right-sided murmurs, like tricuspid regurgitation or pulmonic stenosis, get louder with inspiration. Left-sided murmurs are generally unaffected. It's a great way to tell them apart.
If the murmur is still ambiguous, we have to rely on hemodynamic maneuvers. Let's talk about how Valsalva and squatting change preload and afterload.
Right. So Valsalva straining and standing up both decrease venous return to the heart. They reduce preload.
Less blood in the ventricle.
Exactly. Squatting and hand grip do the opposite. They squeeze the peripheral vessels, increasing venous return and increasing systemic vascular resistance. So they increase both preload and afterload.
Now let's use that for a deep dive on the two conditions with paradoxical responses: mitral valve prolapse and hypertrophic cardiomyopathy.
Okay, mitral valve prolapse. The click and murmur happen when the leaflets prolapse back into the atrium. If you decrease the volume in the ventricle with Valsalva or standing.
The ventricle is smaller, so the leaflets are floppier.
Exactly. The prolapse happens earlier and for longer. So the click moves earlier in systole week and the murmur gets longer and louder.
Right.
When you squat, the ventricle gets bigger, which tightens up the whole apparatus, and the click happens later and the murmur gets shorter and quieter.
The response from HCM is the most unique and important one. Why does the murmur of obstruction get louder when there's less blood in the heart?
It's completely paradoxical.
Yeah.
In HCM, the problem is a muscular obstruction in the outflow tract. When you decrease venous return with Valsalva, the ventricular cavity shrinks. This makes that muscular obstruction even worse, which paradoxically makes the murmur louder.
And when you squat?
When you squat, you fill the ventricle with more blood. This pushes the walls apart, opens up that outflow tract, and decreases the obstruction, making the murmur quieter. This is absolutely essential for diagnosis.
How does that compare to standard aortic stenosis?
Aortic stenosis is a fixed anatomical blockage. The murmur intensity is directly related to how much blood is flowing across it. So maneuvers that decrease flow, like Valsalva, will make the AS murmur quieter. It follows the rules, unlike HCM.
Okay, moving from the chest to the periphery. The circulation often mirrors what's happening centrally. Let's start with edema. What are the two main pressure issues that cause it?
Edema is usually from one of two things. Most commonly, it's increased hydrostatic pressure. The fluid is being pushed out of the vessels. This is what you see in biventricular heart failure.
And the other cause?
Less commonly, it's decreased oncotic pressure. There's not enough protein, usually albumin, in the blood to hold the fluid in. You see this in nephrotic syndrome or severe liver failure.
We also need to look at the hands for signs of systemic infection, especially endocarditis.
Yes. The signs can be subtle, but they're classic. Things like splinter hemorrhages, which are little linear bleeds into the nails, Osler nodes, which are painful nodules on the fingertips, and Janeway lesions, which are painless red spots on the palms and soles.
Now, let's feel the quality of the pulse. If I feel a pulse that is weak and also delayed, what major structural problem should I immediately think of?
That is pulsus parvus et tardus, the small and late pulse. It is the signature finding of severe aortic stenosis. It reflects how long it takes for the blood to get squeezed through that tiny, tight valve opening.
What about a pulse that seems to alternate between strong and weak beats?
That's pulsus alternans. This is a sign of severely impaired left ventricular systolic function, advanced cardiomyopathy. The heart is failing so badly that its stroke volume is literally alternating with each beat.
Then there's the pulse associated with cardiac compression or tamponade.
That's pulsus paradoxus. It's a drop in systolic blood pressure of 10 millimeters of mercury or more during inspiration. It's a critical finding because it's the classic sign of cardiac tamponade, where fluid is squeezing the heart, but you can also see it in severe asthma or COPD.
And a couple of others linked to specific valve and muscle issues.
Yes, the jerky pulse is classically associated with hypertrophic obstructive cardiomyopathy. And pulsus bispherians, the twice-beating pulse, is seen in severe aortic regurgitation, or combination of aortic stenosis and regurgitation.
Okay, let's enter the complex and often dangerous world of electrical instability, arrhythmias. Before we get into specific rhythms, let's talk about the three fundamental mechanisms that cause fast heart rates.
Right. The first is abnormal automaticity. This is when some heart cells just start firing on their own, becoming their own pacemakers. You see this with ischemia or electrolyte problems.
Okay.
The second is triggered activity. This involves these little aftershocks or after depolarizations that can trigger a full beat if they're big enough. This is the mechanism behind torsades de pointe and digoxin toxicity.
And the third and most common is reentry.
Reentry is the most common and the most complex. Imagine an electrical signal that comes to a fork in the road. There's a fast pathway and a slow pathway. Normally, the signal goes down both and cancels out. But if the fast pathway is refractory or recharging, when the signal from the slow pathway gets to the end, that signal can then travel backwards up the fast pathway and re-excite the circuit. It creates a sustained, endless loop. This is the mechanism behind AFib, flutter, and most SVTs.
Let's focus on the most common sustained arrhythmia, atrial fibrillation or AFib. What is the core electrical chaos going on?
AFib is just disorganized, chaotic electrical activity in the atria. This leads to an irregular ventricular rhythm. The chaos is often triggered by these rogue, rapidly firing cells that are usually located in the pulmonary veins.
And AFib is often a disease of systemic stress. What are the big risk factors we need to screen for?
The list really shows that systemic connection: advanced age, hypertension, coronary artery disease, congestive heart failure, diabetes, obesity, obstructive sleep apnea. And one critical treatable cause you must always rule out is hyperthyroidism.
How do we classify AFib?
We classify it in a couple of ways. First, is it valvular, meaning associated with mitral stenosis, or a prosthetic valve, or non-valvular? Then by duration. Is it paroxysmal, meaning it stops on its own, persistent, or long-standing?
And if a patient comes in with new AFib, what are the first steps?
Well, symptoms can range from nothing to palpitations to full-on syncope. The exam shows that classic irregular pulse. The workup starts with an ECG, basic labs including a TSH to check the thyroid, and an echocardiogram to look for any underlying structural problems.
Okay, let's shift to the slow rhythms, the AV blocks. These tell us about the health of the conduction system. Let's start with the simplest, first-degree AV block.
First-degree AV block is just a consistent delay. The PR interval is always longer than 200 milliseconds, but every single beat still gets through from the atria to the ventricles.
So no dropped beats.
No drop beats. It's usually asymptomatic and doesn't need treatment, but it's a good reason to check the patient's medication list for things like beta blockers.
Okay, the second-degree blocks are where the real diagnostic challenge lies. Why is Mobitz type 1 or Venkabuck usually more benign than Mobitz type 2?
It all comes down to where the block is happening. In Mobitz type I, you see the PR interval get progressively longer and longer and longer until finally a beat is dropped. The problem is in the AV node itself.
So it's a fatigue problem.
It's a fatigue problem. It's often caused by drugs or high vagal tone. It shows the node is getting tired, but the underlying system is okay. Treatment is usually just observation or stopping the offending drug.
Mobitz type 2, on the other hand, is much more ominous.
It's malignant. With Mobitz II, you have a constant PR interval, and then suddenly, out of nowhere, a beat is dropped. This block is happening below the AV node, his Purkinje system.
Which is much more danger.
Much more. It has a high risk of suddenly progressing to a complete third-degree heart block. So the treatment is a permanent pacemaker, even if the patient feels fine at the moment.
That brings us to third degree or complete heart block. What is the electrical signature of that total dissociation?
Third-degree block is a complete electrical divorce between the atria and the ventricles. On the ECG, you see P waves marching along at their own rate and QRS complexes marching along at their own much slower rate. They're completely independent.
So there's no communication.
Zero communication. The ventricles are being driven by a slow, unreliable escape rhythm. It's an emergency that always requires a pacemaker.
And what about sick sinus syndrome or Tachi-Brady syndrome?
This is a complex failure of the SA node. Patients have these alternating periods of fast rhythms like AFib or flutter, and then periods of very slow rhythms like severe bradycardia or long sinus pauses.
So it's the worst of both worlds.
It really is. They need anticoagulation because of the AFib and the high stroke risk, and they often need a pacemaker to treat the symptomatic bradycardia. The pacemaker prevents the heart from going too slow, which then allows you to safely use medications to control the fast rhythms.
Let's go back to the fast rhythms, the supraventricular tachycardias or SVTs. Let's start with atrial flutter, which has that classic sawtooth pattern.
Atrial flutter is a very rapid but very regular atrial rhythm, usually around 300 beats per minute. It's driven by a large reentry circuit, often in the right atrium.
And the AV node can't keep up.
Right. The AV node acts as a filter. It usually has a fixed block, like a 2-to-1 or 4-to-1 block, leading to a ventricular rate of 150 or 75. Treatment is anticoagulation, rate control, and often catheter ablation of that circuit is curative.
What about AV nodal reentrant tachycardia, AVNRT? It often presents with a very specific rate, around 150.
It does. AVNRT is a tiny reentry circuit that's contained entirely within the AV node itself. The rate is typically right around 150. Because the P wave travels backwards, it's often buried inside the QRS complex, so you don't see any P waves.
And how do we break that circuit acutely?
If the patient is unstable, you cardiovert them. If they're stable, you start with vagal maneuvers, have them bear down, or do a carotid massage. This can slow the AV node and break the rhythm.
And if that doesn't work?
The next step is IV adenosine. It's a drug that briefly stops the AV node completely, which will almost always terminate the rhythm.
Now for the big one with an accessory pathway, Wolff-Parkinson-White, or WPW. This is a high-risk diagnosis we cannot miss.
Right. In WPW, there's an extra electrical connection, an accessory pathway that bypasses the AV node. This causes the ventricles to get pre-excited.
And what's the classic ECG triad?
The triad is a short PR interval because you're bypassing the normal delay, a widened QRS complex, and the hallmark delta wave, which is that slurred upstroke of the QRS.
Why is this such a high-stakes diagnosis?
Because if a patient with WPW develops atrial fibrillation, that accessory pathway can conduct those hundreds of chaotic atrial impulses directly down to the ventricles, leading to ventricular fibrillation and sudden death.
This brings us to a massive clinical takeaway. What drugs are absolutely contraindicated in a patient with WPW who is in AFib?
This is a life-saving piece of knowledge. You must not use standard AV nodal blockers. That means no calcium channel blockers like verapamil or diltiazem, no digoxin, and no beta blockers.
Why?
Because if you block the normal, safe pathway through the AV node, you force all of that chaotic AFib traffic down the fast, dangerous accessory pathway. This can accelerate the ventricular rate to fatal levels. The acute treatment is procainamide or amiodarone, and long-term, catheter ablation to destroy the pathway is curative.
Okay, one more SVT. Multifocal atrial tachycardia, or MET.
MET is strongly associated with severe lung disease, especially COPD and hypoxia. The ECG criteria are strict. You need to see at least 3 different unique P-wave morphologies at a rate over 100. It means multiple spots in the atria are all firing off.
And treatment?
The treatment is to treat the underlying lung problem, improve their oxygenation. You generally avoid antiarrhythmics and just focus on the lungs.
All right, we're done with the atria. Let's move down to the bad neighborhood. The ventricles, where things get really dangerous, starting with the very common premature ventricular contraction, or PVC.
But PVC is just an early beat that comes from the ventricles. On the ECG, it looks wide and bizarre. It's not preceded by a P wave, and it's usually followed by a compensatory pause.
Are they dangerous?
Usually not. They can be a sign of hypoxia or electrolyte problems, but in a healthy heart, they're often benign. You treat the underlying cause if there is one.
Okay, let's move up to ventricular tachycardia, or VT. What's the difference between non-sustained and sustained VT?
VT is a rapid, regular rhythm of wide QRS complexes. Non-sustained VT lasts for less than 30 seconds and stops on its own. Sustained VT lasts longer than 30 seconds and is a true emergency. It can cause syncope or full cardiac arrest.
And the treatment depends entirely on whether they have a pulse.
Exactly. If the patient is unstable, low blood pressure, altered, they need an immediate synchronized cardioversion, an electrical shock. If they're stable and have a decent blood pressure, you can try antiarrhythmic drugs first, like amiodarone or lidocaine.
Then there's ventricular fibrillation, VFib, total chaos.
VFib is cardiac arrest, period. It's completely erratic, chaotic tracing. There is no pulse, no blood pressure. It is non-perfusing electrical chaos. This requires immediate, unsynchronized defibrillation, a high-energy shock, and full ACLS protocol.
Finally, torsades de pointes. It has that very distinct twisting look.
It does. Torsades is a type of polymorphic VT, where the QRS complexes seem to twist around the baseline. It's caused by a long QT interval, often triggered by low potassium or low magnesium.
And what's the specific acute treatment for torsades?
If they're pulseless, you defibrillate. But the key pharmacologic treatment, the first-line drug, is unique. Intravenous magnesium. That is the answer. Then you aggressively correct the potassium levels.
Let's circle back to atrial fibrillation and its long-term management. It's a two-pronged approach: stroke prevention and rate or rhythm control. We have to start with the CHIDES-2 VSC score.
Stroke prevention is absolutely paramount in AFib because of the risk of a clot forming in the left atrial appendage. The CHIDES-2 VSC score is how we estimate that risk.
Walk us through the components.
It's an acronym. C for congestive heart failure, H for hypertension, A for age, you get 1 point for 65-74, 2 points for 75 or older, D for diabetes, and S for a prior stroke or TIA, which is so high risk it gets 2 points.
And the last two.
V for vascular disease. And then there's a sex category where a female sex gets 1 point. Basically, a score of 2 or more in men or 3 or more in women means you should be on long-term anticoagulation.
And what are the preferred anticoagulants now?
The direct oral anticoagulants, or DOACs, drugs like aditizoban, rivaroxaban, are now preferred over warfarin for most patients. They're safer and easier to manage. Warfarin is still needed for patients with mechanical valves or significant mitral stenosis.
Okay, now the big strategic question: rate control versus rhythm control. What does the evidence tell us?
For a long time, we thought restoring a normal rhythm was better. But big trials have shown that for most patients, a strategy of rate control, just controlling the ventricular rate and leaving them in AFib, is just as good, if not better, in terms of mortality.
So what's the goal for rate control?
The goal is a heart rate of less than 110 at rest. The best initial drugs are beta blockers or non-dihydropyridine calcium channel blockers.
So when do we choose a rhythm control strategy?
Rhythm control is mainly for symptom management. If a patient is really symptomatic despite good rate control, then you might try to restore a normal rhythm with drugs, electrical cardioversion, or ablation, but it doesn't improve mortality.
And the timing of cardioversion is a huge safety issue.
It is. If the AFib has been going on for more than 48 hours, there's a high risk of a clot in the atrium. So you either need to anticoagulate them for 3 full weeks before the cardioversion, or you do a transesophageal echo, a TE, right beforehand to make sure there's no clot.
Okay, let's move on to cardiac life support and then congestive heart failure. Let's quickly review the ACLS protocols for when the heart stops.
We divide the rhythms into shockable and non-shockable. The non-shockable rhythms are asystole, a flat line, and pulseless electrical activity, or PEA.
What's the treatment there?
For those, it's immediate high-quality CPR and epinephrine. A shock is absolutely not indicated and will do nothing.
And the shockable rhythms.
The shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. For these, the treatment is an immediate unsynchronized shock, defibrillation, followed by CPR, epinephrine, and antiarrhythmics like amiodarone.
We need to be crystal clear on the difference between synchronized cardioversion and defibrillation.
Right. Synchronized cardioversion is a lower energy shock that is timed to the patient's R wave. We use it for unstable patients who still have a pulse but are in a fast rhythm like SVT, AFib, or VT with a pulse. The timing is crucial to avoid shocking on the T wave, which could cause VFib.
And defibrillation.
Defibrillation is a high-energy, untimed shock. It's a total reset. It's only for the non-perfusing pulseless rhythms, VFib and pulseless VT.
What I find critical about the 5 H's and 5 T's for PEA is that it forces you to think about reversible causes.
Exactly. When you have electrical activity but no pulse, something is preventing the heart from pumping. You have to find and fix that problem. The H's are hypovolemia, hypoxia, hydrogen ion, acidosis, or hyperkalemia.
And hypothermia.
And the T's. The T's are TAMPTADE, tension, pneumothorax, thrombosis, a massive PE or MI, toxins, and trauma. Finding and treating one of these is the only way to get a pulse back.
Okay, let's transition now to chronic disease, specifically congestive heart failure, or CHF. At its core, it's just the heart failing as a pump, right?
That's it. It's a syndrome where structural or functional problems mean the heart can't supply enough blood to meet the body's demands. The big risk factors are coronary artery disease, hypertension, valve disease, and diabetes.
The modern way to classify it is based on the ejection fraction, or EF.
Yes, divided into 3 main groups. First is heart failure with reduced ejection fraction, or HFrEF. Here, the LVEF is 40% or less. This is a systolic problem. The heart can't squeeze.
And the others.
Then there's heart failure with preserved ejection fraction, or HFpEF. Here, the LVEF is 50% or more. This is a diastolic problem. The heart is stiff and can't relax and fill properly. And there's a middle group, HFMREF, that's in between.
We still use the New York Heart Association, or NYHA, classification to grade symptoms, right?
We do. It's a simple way to track how limited the patient is. Class 1 is no limitation. Class 2 is slight limitation with ordinary activity. Class 3 is marked limitation. They're only comfortable at rest. And Class 4 is they have symptoms even at rest.
And we have to distinguish between left-sided and right-sided heart failure symptoms.
Right. Left-sided failure causes fluid to back up in the lungs. So you get dyspnea, orthopnea, crackles in the lungs, pulmonary edema.
And the most common cause of right-sided failure is?
Left-sided failure. The fluid backs up from the lungs into the right side of the heart and then into the body. So with right-sided failure, you see systemic fluid retention, peripheral edema, JVD, ascites.
Let's talk about the core pathophysiology, that vicious cycle of compensation that actually makes things worse.
It's all about the chronic activation of neurohormonal systems. When the cardiac output falls, the body panics and activates the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAAS.
Which is supposed to help.
Initially, yes. It causes vasoconstriction and fluid retention to try and maintain blood pressure, but long-term, this is toxic. It increases the afterload and preload, making the heart work even harder against more resistance and with more volume. This leads to pathological remodeling. The heart gets bigger, weaker, and more fibrotic, and the failure just gets worse and worse over time.
When a patient comes in with an acute decompensation, what's the best initial test to figure out what's going on mechanically?
The echocardiogram is essential. It tells you the EF, looks for valve problems, and shows you the chamber sizes. And in the blood, the key lab is the brain natriuretic peptide, or BNP. An elevated BNP confirms that the ventricle is being stretched under high pressure.
The treatment for acute CHF is all about hemodynamic profiling. You have to figure out if the patient is warm or cold and wet or dry.
This is the first and most important step. Warm means they're well perfused. Cold means they're in shock, hypoperfused. Wet means they're congested with fluid. Dry means they're not.
Let's talk about the most common profile, wet and warm.
Wet and warm means they're congested, but their blood pressure is stable. The goal is decongestion. The treatment is IV diuretics like furosemide and often vasodilators like IV nitroglycerin to reduce preload and afterload.
Now, what if they're wet and cold? This is much more serious.
Wet and cold is cardiogenic shock. They're congested and hypoperfused. Here you have to be very careful with diuretics. If their blood pressure is low, the priority is to restore perfusion. This often means starting inotropes like dobutamine or milrinone to make the heart squeeze harder. Diuretics come later, once their perfusion is better.
Okay, let's talk about the long-term medications for chronic HFrEF. These are the drugs that actually save lives. But let's start with diuretics for symptoms.
Right, diuretics are for symptom control. The most potent are the loop diuretics, like furosemide. The big side effects are potassium and magnesium wasting and potential ototoxicity at high doses.
And the potassium issue is a huge deal in heart failure.
It is. That's why the other key class of diuretics are the potassium-sparing ones, specifically the mineralocorticoid receptor antagonists, or MRAs, like spironolactone and uplurenone.
And these are more than just diuretics.
Much more. They are one of the 4 pillars of mortality-reducing therapy in HFrEF, but their main side effect is, not surprisingly, hyperkalemia.
So what are the other 3 pillars of chronic HFrEF therapy?
Okay, the 4 cornerstone drug classes that reduce mortality are, first, an ARNI, which is the combination of sacubitril and valsartan, or an ACE inhibitor, or ARB. Second, a specific evidence-based beta blocker, like carvedilol or metoprolol succinate.
And the last 2?
A third are the SGLT2 inhibitors, drugs like dapagliflozin and empagliflozin. And fourth, as we said, are the MRAs, like spironolactone. Every patient with HFrEF should be on these 4 classes if possible.
What about some of the older drugs like digoxin?
Digoxin helps with symptoms and reduces hospitalizations, but it does not improve mortality. It has a very narrow therapeutic index, and toxicity is a major concern.
And finally, when do we move to devices?
An implantable cardioverter defibrillator, or ICD, is indicated for primary prevention in patients with an LVEF of 35% or less to protect them from sudden cardiac death. And cardiac resynchronization therapy, or CRT, which is a biventricular pacemaker, is used for patients with a low EF and a left bundle branch block to help the ventricles beat in sync.
Let's spend a minute on heart failure with preserved ejection fraction, HFpEF. This is the diastolic dysfunction, the stiffness problem.
Right. The EF is normal, but the heart can't relax and fill. So you get high filling pressures and the same symptoms as HFrEF. It's often seen in older, hypertensive patients.
And the treatment has been notoriously difficult, right?
For a long time, yes. Diuretics are the mainstay for symptom relief. But until very recently, no drug was proven to reduce mortality. The big breakthrough is that SGLT2 inhibitors like empagliflozin have now been shown to have a mortality benefit in HFpEF as well.
And what's crucial is that many of the drugs for HFrEF, like digoxin and spironolactone, are not beneficial in HFpEF.
Correct. The focus is on aggressive blood pressure control and heart rate control to maximize the time the heart has to fill in diastole.
Okay, let's shift from the syndrome of heart failure to diseases of the heart muscle itself. The cardiomyopathies. Let's start by comparing the 3 major types.
Right. We classify them by their morphology. First is dilated cardiomyopathy, or DCM. The major abnormality is impaired contractility. The LV cavity is huge, like a floppy balloon, and the EF is low.
And hypertrophic.
Hypertrophic cardiomyopathy, HCM, is the opposite. The problem is impaired relaxation. The LV cavity is small, the walls are super thick, and the EF is often normal or even high.
And the third type, restrictive.
Restrictive cardiomyopathy, RCM, is an issue of impaired elasticity. The walls are stiff and rigid, so they can't fill. The LV cavity is small, and the EF is usually normal, but the atria are massively dilated from the back pressure.
Let's focus on dilated cardiomyopathy first. What are the key secondary causes we need to know?
Besides idiopathic or genetic causes, there's a long list. Chronic alcohol abuse is a big one, post-viral myocarditis. Certain chemotherapies like doxorubicin, cocaine use, and of course the most common overall cause of a dilated weak heart is ischemic heart disease.
And clinically, it just presents like standard systolic heart failure.
Exactly. You'll see all the classic CHF symptoms, and on exam, you'll hear an S3 gallop from the volume overload. The echo confirms the big floppy heart, and the treatment is the standard four-pillar HFrEF regimen.
Okay, hypertrophic cardiomyopathy. This is the genetic disease that is terrifyingly known as the most common cause of sudden cardiac death in young athletes.
It is. It's an autosomal dominant genetic disorder that causes the heart muscle, especially the septum, to thicken immensely.
Oh,
This leads to diastolic dysfunction, and in many cases, it also causes an obstruction to blood flow, leaving the heart.
and the physical exam findings are key. The S4 gallop and that unique murmur response.
Right. You hear an S4 gallop because of the stiff ventricle. And as we discussed, the systolic murmur gets louder with maneuvers that decrease the heart's volume, like Valsalva.
How do we treat this high-risk
The
condition?
goals are symptom relief and preventing sudden death. First-line drugs are beta blockers to slow the heart rate and give it more time to fill.
And what are the drugs that are absolutely forbidden in HCM?
This is critical. You must avoid digoxin, diuretics, and vasodilators. Anything that decreases the volume in the ventricle will make that outflow obstruction worse and can cause the patient to collapse. High-risk patients get an ICD, and some may need surgery to shave down the thickened muscle.
Okay, a couple of other important cardiomyopathies. Arrhythmogenic right ventricular dysplasia, ARVD.
ARVD is another genetic disease, the second most common cause of sudden death in the young. Here, the muscle of the right ventricle is progressively replaced by fibrofatty tissue. This creates a very unstable electrical environment.
And the ECG finding is very specific.
Yes, you see inverted T waves in the right precordial leads, V1 to V3, and often a characteristic little blip at the end of the QRS called an epsilon wave. Treatment is all about preventing sudden death with an ICD.
And restrictive cardiomyopathy. This is a filling problem caused by a rigid wall. What are the main infiltrative causes?
The most common cause of RCM is amyloidosis, where abnormal proteins infiltrate the heart muscle. Other causes are sarcoidosis and hemochromatosis, which is iron overload.
And it presents with signs of severe right heart failure, right?
Yes, because the right ventricle is thin-walled and very sensitive to this restriction, so patients get massive JVD, edema, and ascites. The ECG paradoxically often shows low voltages, despite the thick walls, especially in amyloidosis. Treatment is really just palliative and aimed at the underlying disease.
Let's touch on three final unique cardiomyopathies. First, myocarditis.
Myocarditis is inflammation of the heart muscle, usually after a viral infection. It can present with a flu-like illness, chest pain, and new-onset heart failure or arrhythmias. Treatment is supportive care for the heart failure.
Peripartum cardiomyopathy.
This is a form of dilated cardiomyopathy that occurs for unknown reasons in the last month of pregnancy or the first few months postpartum. Treatment is standard heart failure therapy, but it's critical to counsel women that if their heart function doesn't fully recover, another pregnancy could be fatal.
And the fascinating broken heart syndrome, Takotsubo cardiomyopathy.
Takotsubo is triggered by intense emotional or physical stress. It presents exactly like a heart attack, chest pain, ST elevation, positive cardiac enzymes. But when you take them for an angiogram, their coronary arteries are wide open, completely clean.
So what's happening?
The echocardiogram shows this characteristic ballooning of the apex of the left ventricle. The cause is thought to be a massive catecholamine surge that stuns the heart muscle. The prognosis is generally good, and the heart function usually recovers.
Okay, last major section. Let's pivot to the plumbing itself. Coronary artery disease and acute coronary syndromes.
Right, the leading cause of heart problems globally. Angina pectoris is the classic symptom. It's chest pain from an oxygen supply and demand mismatch, usually because of a fixed blockage in a coronary artery.
And we use the 321 classification to define typical chest pain.
Exactly. Typical angina has all three features. One, it's substernal chest pain. Two, it's provoked by exertion or stress. And three, it's relieved by rest or nitroglycerin. If you have two of the three, it's atypical. One of the three, it's non-cardiac.
For diagnosing stable angina, where do we start? And why is it essential that the cardiac enzymes are negative?
The initial test is a resting ECG, which is often normal. The enzymes, like troponin, must be negative, because if the troponin is elevated, it means heart muscle cells have died. That's not stable angina anymore. That's an acute coronary syndrome.
So for stable angina, we move to stress testing.
Yes. For patients with an intermediate probability of disease, If they can exercise, they go on a treadmill for an exercise ECG. If they can't, we do a pharmacologic stress test with drugs that mimic the effects of exercise.
There's one specific type of angina caused by vasospasm, not a fixed blockage, Prinzmetal angina.
Right. This is caused by a spasm of the coronary artery, often in younger smokers. The pain happens at rest, often at night. And during the spasm, the ECG shows transient ST segment elevation.
And the treatment is completely different.
It is. The treatment is calcium channel blockers and nitrates. And crucially, beta blockers are strictly contraindicated. They can block the beta-2 receptors that cause vasodilation, leaving the alpha receptors unopposed and potentially making the vasospasm worse.
Okay, that brings us to the acute coronary syndromes, unstable angina and STEMI. The differentiation is all about biomarkers and the ECG.
Correct. Unstable angina is when the chest pain is new, getting worse, or happening at rest, but there is no elevation of cardiac biomarkers. Ischemia happened, but no significant cell death.
And STEMI, a non-ST elevation MI. What's the only difference from unstable angina?
The troponin. In NSTEMI, you have ischemic symptoms and an elevated cardiac biomarker confirming that myocardial necrosis has occurred. But there's no ST elevation on the ECG. This is usually from a partial occlusion of the artery.
And how do we manage these patients?
We risk stratify them using scores like the TIMA score. High-risk patients go for an early invasive strategy, meaning a cardiac catheterization within 24 hours. Low-risk patients can be managed more conservatively with medications first.
Finally, the big one, ST segment elevation myocardial infarction, a STEMI.
A STEMI is a true medical emergency. It's a complete, sustained occlusion of a coronary artery, leading to a full-thickness transmural infarction. Patients have severe, prolonged chest pain.
And the ECG is the key to diagnosis.
The ECG shows new ST segment elevation in at least 2 contiguous leads, or a new left bundle branch block, which is considered a STEMI equivalent.
Initial treatment is the MEPDS protocol.
Right. Morphine, oxygen if needed, nitrates, aspirin plus a second antiplatelet drug, beta blockers, and a high-intensity statin.
But the ultimate treatment is getting that artery open fast.
Time is muscle. The goal is reperfusion. For a hospital with a cath lab, the goal for door-to-balloon time for a PCI should be under 90 minutes. If that's not possible, then fibrinolytic or clot-busting drugs are the alternative.
And long-term post-MI care.
It's all about secondary prevention. Dual antiplatelet therapy for at least a year, beta blockers, ACE inhibitors, and high-intensity statins. All of these are proven to reduce the risk of another event.
This has been an incredibly rigorous deep dive. We have covered a massive amount of high-yield cardiovascular pathology.
We really have. We've tried to synthesize everything from those precise electrical intervals that can diagnose a congenital risk, all the way to the complex hemodynamics that define the different types of heart failure and cardiomyopathy.
It's about connecting the diagnostic tools, like an ECG axis or a murmur, directly to the underlying physiology.
Exactly. Connecting the finding of Mobin's 2 block directly to the idea of intrinsic disease in his Purkinje system, or connecting the symptoms of heart failure directly to the chronic toxic activation of the RAS system.
The critical thinking is everything. Like how you triage a patient with chest pain, differentiating a high-risk NSTEMI, which needs an invasive approach, from lower-risk unstable angina based on that one single biomarker, the troponin.
That's right. That one piece of data changes the entire plan.
We've really seen the vast range of mechanisms the heart uses to cope, from those complex re-entry circuits of arrhythmias to the compensatory neurohormonal pathways of chronic heart failure, which I think raises a final, really profound question for you to think about.
And what's that?
When does the heart's impressive capacity for adaptation through things like hypertrophy or hormonal activation finally become its own downfall? And what is the key factor that eventually tips that scale into irreversible terminal failure? That is something for you to mull over and explore on your own.